Good evening. We'll be starting right now. So, our
Let's start.
topic
Let's
today is adrenocortical insufficiency, and the speaker that we have here is Dr. Nikhilesh Jain, who is the Director and Operational Head Depth of Critical Care Services Care at CHL Hospital Indore. And our organizers for today's are Dr. Akhilesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal. Thank you. So you may start.
Okay, so adrenal insufficiency. I am being asked to talk about this topic. Uh, Seems very innocuous because it's very simple. You all of us know how to treat adrenal crisis, but when you go into depth of it, probably you have to, learn about a lot of physiology, which is involved in adrenal insufficiency. Probably what is primary, what is secondary, a bit of tertiary, and what are the common things that you may find in these patients. So a bit of it regarding usual presentations, a bit of it regarding acute presentations, and we'll finish off with certain trials regarding adrenals in critical care. So the first case vignette, you've got a 35-year-old woman who presents to the emergency department. She has progressive fatigue, nausea, vomiting, weight loss, along with giddiness over the past few months. She also gives history of darkening of her skin, particularly on elbows,
Hello.
knees, and the inside of her mouth. On examination, she's got a blood pressure of 90 by 60 with a postural drop of 20 mm of mercury, heart rate of 95 beats per minute, skin shows hyperpigmentation on knuckles, gums, and palmar creases. When we go to labs, it shows a sodium of 126 milliequivalent per liter, which is low, potassium of 5.8 milliequivalent per liter, which is high, glucose of 65 milligram per deciliter, which is again low, serum cortisol, 8 am serum cortisol is characteristically low, and ACTH levels remain high. Renin levels are elevated and aldosterone levels are low. So this is a classical primary adrenal insufficiency that we are talking about. It can progress on to develop into addisons. So we go to the second case. You've got a 50-year-old male. He's got a history of chronic steroid use for rheumatoid arthritis. And this guy suddenly stops taking his steroids, prednisolone, and he develops severe fatigue, muscle weakness, nausea, and confusion. He comes to you on examination. At baseline, his BP is found to be 95 by 60, heart rate of 88 beats per minute with no hyperpigmentation. Sodium is low, potassium is normal, and glucose is again low. When you look at serum cortisol levels and the ACTH levels, they are low. So both of them being low, it's likely to be a secondary adrenal insufficiency. So going on to the third case beginner, you've got a 60-year-old man with this guy is a known Addison's disease. He is brought to the ER in shock. His family reports that he had a fever and vomiting for 2 days, and he was unable to take his regular hydrocortisone and fluorocortisone medications. On examination, he is found to have severe hypotension in the range of 70 by 40 mm of mercury, heart rate of 120 beats per minute, febrile at a temperature of 101 degree Fahrenheit, skin is pale and clammy. Labs show you to have a low sodium, high potassium, low sugars, along with BUN creatinine ratio, which is elevated, more in favor of a pre-renal vasculitis. So this is a classical case of adrenal crisis. And to complete the spectrum, you've got a case vignette 4. Now, this is basically a 45-year-old woman with history of a pituitary macroadenoma and who has come to you as a case of status post-surgery. She presents to you with fatigue, weight loss, and cold intolerance over the past few months. On examination, BP is 100 by 70, heart rate of 80 beats per minute, skin does not show any hyperpigmentation. Sodium is mildly low in the form of 133 milliequivalent per liter. Potassium is normal. Sugars are low. Cortisol levels are low, and ACTH is near to undetectable. Now here, TSH and free T4 are also low, so suggesting there is a central hypothyroidism as well. So here, because of the pituitary surgery, you are also finding hypothyroidism coming in, and this is a case of tertiary adrenal insufficiency. So this discussion apart, now we go on to some more discussions. So symptoms and signs of adrenal insufficiency, they will actually depend on rate and extent of loss of adrenal function. They would also depend on the fact whether your mineralocorticoid production is preserved or not. It would also depend on the fact that how much degree of physical stress is something that you see. Now, the onset of adrenal insufficiency is often very gradual. and it may go undetected until an illness or a form of stress actually tends to precipitate adrenal crisis. So what are the classical clinical features? You've got dehydration, hypotension, or shock, which is out of proportion to the severity of current illness. These patients present to you with nausea and vomiting with history of weight loss and anorexia for some time. You can get a so-called acute abdomen with abdominal pain. There can be some unexplained hypoglycemia and unexplained fever. In form of dyselectrolytemia, you can get hyponatremia, hyperkalemia, azotemia, hypercalcemia, or eosinophilia. There may be some amount of characteristic hyperpigmentation or vitiligo. There may be coexistent other autoimmune endocrine deficiencies such as hypothyroidism or gonadal failures. Now, what about the physiology? So, do remember when we talk in terms of physiological manifestations, here both mineralocorticoid and glucocorticoid deficiency can technically contribute. Aldosterone tends to promote sodium retention and tends to enhance the vasoconstrictor responses of vasculature. Hence, if the patients are receiving a synthetic glucocorticoid and at physiologic or pharmacologic doses, if their mineralocorticoid requirements are not met, then these patients develop a crisis. So how does glucocorticoid deficiency translate into hypotension? Well, you get a decreased vascular responsiveness to angiotensin 2 and other catecholamines. There's a decreased synthesis of renin substrate. There's an increased prostacyclin production. You get a decreased serum epinephrine and compensatory increases in serum norepinephrine concentrations. You get a lower basal systolic blood pressure and you get an exaggerated increase in pulse rate in response to upright posture. So what are the precipitating factors? So serious infection or other acute major stress in patients of chronic primary adrenal insufficiency. Insufficient replacement doses or failure to take a higher dose in stressful situations in known patients, or vomiting or diarrhea, which leads to decreased absorption of these medications. So it could be either primary or central adrenal insufficiency. Then you can have an acute adrenal gland destruction because of infarction or bleed, which is again primary insufficiency. You can get a pituitary infarction, again leading to central adrenal insufficiency. Along with that, it can happen that there has been an abrupt withdrawal of supraphysiologic doses of steroids, which has led to this system, which has led to this sort of a picture. So what about manifestations? So weakness, tiredness, fatigue. Patients might present to you with anorexia, GI symptoms in the form of nausea, vomiting, constipation, abdominal pain and diarrhea, salt craving, muscle or joint pains, postural giddiness. In terms of signs, if the patient has a documentation, you may find evidences of weight loss, hyperpigmentation, hypotension in the form of systolic BP, which is defined as less than 110 mm of mercury for this particular situation, vitiligo, as well as auricular calcifications. Then you can get lab abnormalities in the form of electrolyte disturbances such as hyponatremia, hyperkalemia, and hypercalcemia. As discussed, elevated bun-creatinine ratio leading to azotemia. Along with that, you can get anemia and eosinophilia. So when we talk in terms of what should be the treating principles for this, basically said, it is inadequate cortisol production to meet your physiologic needs. Primary adrenal insufficiency, which is also referred to as Addison's disease, results from disorders of adrenal cortex, whereas secondary and tertiary adrenal insufficiencies are due to dysfunction of pituitary gland and hypothalamus. If you have a primary adrenal insufficiency, it leads to both glucocorticoid as well as mineralocorticoid. Here, principally aldosterone, that's what we are referring to, deficiency. And a central adrenal deficiency, that is whether it is secondary or tertiary, it causes glucocorticoid, but not mineralocorticoid deficiency. Why? Because aldosterone is regulated primarily by the renin-angiotensin system and it works independently of the hypothalamus and pituitary. So what are your emergent treatment options? You establish an IV access with a large gauge needle. You do your serum creatinins, BUNs, electrolytes, glucose, and routine measurements of plasma cortisol and ACTH. Remember that I'll be keeping on stressing this thing. Do not wait for your lab reports to come in before you start this treatment. Infuse 1 liter of normal saline or D5 in isotonic saline as quickly as possible. You repeat fluid bolus as needed for volume resuscitation followed by maintenance fluids. Frequent hemodynamic monitoring and measurement of serum electrolytes should be performed to avoid an iatrogenic fluid overload. Hydrocortisone can be given in the dose of 100 mg IV bolus followed by 50 mg IV every 6 hours. Or you can give 200 mg every 24 hours as a continuous IV infusion. for first 24 hours at least. If there is no availability of hydrocortisone, alternatives that can be given, they include methylprednisolone and dexamethasone. Saline must be administered if dexamethasone is given instead of hydrocortisone, and use supportive measures as needed. Once this patient gets stabilized, you continue your IV normal saline at a slower rate for the next 24 to 48 hours. Treat your possible infectious precipitating causes. You taper the IV glucocorticoid over 1 to 3 days. If your precipitating or complicating illness permits you, then switch them over to an oral maintenance dose. If it's a primary adrenal insufficiency, you begin mineralocorticoid replacement with fludrocortisone 0.1 mg per oral when normal saline is stopped, or if your hydrocortisone dose is tapered to less than 40 milligram per daily. Now remember that if your dose is more than 40, you need not give fludrocortisone additionally to these patients. If adrenal insufficiency is unknown, try to confirm the diagnosis and determine the underlying cause. So when do you suspect adrenal insufficiency? It is good to say that you should treat it, but when do you suspect it? So you've got a patient with vasodilatatory shock, which is more like adrenal crisis. And then symptoms and signs of chronic adrenocortical insufficiency is what you see there. Dyselectrolytemia in the form of hyponatremia, which is seen more with primary or central, whereas hyperkalemia, which is seen more in primary insufficiency only. Unexplained severe hypoglycemia or hyponatremia, which can be seen secondary to isolated ACTH deficiencies. Then patients who are on chronic glucocorticoid therapy in the form of withdrawal or withdrawal of the steroid, or whenever pre-op evaluations are done, these patients are kept NBM and the drug is stopped. So how do you test the same? It is good to talk about it, but how do you test it? So what you do is you do a basal level, basal cortisol level and corticotrophin stimulated serum cortisol level, wherein you try to prefer a total serum cortisol, free plus bound patients, except in those patients who have got an abnormal albumin or CBG values, it is cortisol binding globulin values. You look at aldosterone and renin levels if feasible. If your cortisol and ACTH levels are indeterminate, then you go in for testing your dehydroepiandrosterone sulfate levels. I'll be putting in an algorithm for the same. But my problems are, basal cortisol levels do not definitively establish the presence or absence of adrenal insufficiency. If you've got a single early morning serum cortisol value, it may be inconclusive as cortisol secretion is episodic. An ACTH stimulation test may be required for the above situation simultaneously. And with an abnormal cortisol binding globulin, the usual serum cortisol thresholds which we use in the labs can actually lead to an incorrect diagnosis, in the sense that your levels at which you tend to react or at which you tend to supplement may be variable. You can check for salivary cortisol or cortisone levels, which may be useful in patients who have got abnormalities of cortisol binding globulin. But the problem with checking salivary levels is they are not available easily everywhere. And secondly, specific lab thresholds for the same are not well defined. What about adrenal crisis? You put in an IV line, you measure your serum cortisol and plasma ACTH level. Cortisol does not need to be measured in the early morning if you're suspecting an adrenal crisis. You send off a sample that then and there. Once you send off the sample, IV saline and glucocorticoids should be initiated immediately. And reports, as I discussed before, should not delay treatment. I would be reiterating this point again and again. And what about cutoffs? If you've got a cortisol level which is less than 18 microgram per deciliter, it favors adrenal insufficiency. And to confirm the same, we need to do an ACTH stimulation test later. If 40 to 200 milligram of hydrocortisone has not been given earlier for a few days, then we can do the test even after glucocorticoids have been initiated. But most of the times, the type of doses that we give for hydrocortisone are much more. So we are not able to do an ACTH stimulation test. If you're going to do an ACTH stimulation test, you withhold the glucocorticoids on the morning of the test and resume after the test is completed. If your serum cortisol level is more than or equal to 18 microgram per deciliter, adrenal insufficiency is unlikely. Keep in mind that if your patient is pregnant or if your patient has been taking oral estrogens in the form of contraceptive pills, interpretation has to be very cautious, because in these patients, the cortisol binding globulin levels are increased. So what about chronic insufficiency? So if we look at it, try to do this. So, we review the history for conditions of medications that cause abnormal cortisol binding globulin. You measure your serum cortisol levels between 6 to 9 a.m. If your serum cortisol levels are less than or equal to 3, adrenal insufficiency is likely. If your serum cortisol level is more than 3 but less than 18, so these are indeterminate results. So this is the category in which you perform your 250 microgram ACTH stimulation tests. The measurements that you do are baseline serum cortisol, and you repeat the serum cortisol at 30 to 60 minutes after the injection. If your serum cortisol levels are more than or equal to 18, it's a normal adrenal function. So adrenal insufficiency and normal adrenal function are very easy to delineate. Only if the values lie between more than 3 and less than 18, that's where your ACTH stimulation test comes in. So what is the peak cortisol once you've done it? If your serum cortisol levels are less than 14, adrenal insufficiency is likely. If it is again 14 to 18, so in this, it becomes very much an individual take on how you would like to interpret these findings. The likelihood of adrenal insufficiency in an individual patient and the type of assay that has been used to measure cortisol. If your serum cortisol again comes out to be more than or equal to 18, so it is a normal adrenal function. So what are the final points of ACTH testing? You try to use a standard high dose test, which is considered to be a standard, and it should be performed to establish the diagnosis of adrenal insufficiency. Patients who are taking glucocorticoids must withhold them on the morning of the test and resume after the test is completed. You administer a 250 microgram dose of ACTH. It results in a supraphysiologic plasma ACTH concentrations of approximately 60,000 picogram per ml. If your loss of ACTH trophic action is recent, such as within 4 to 6 weeks after pituitary surgery, the ACTH stimulation test actually may be falsely normal. And this is the setting in which you need to go for other tests such as insulin-induced hypoglycemia or a metadapone-induced hypocortisol. Some more facts. Do remember, when we talk about values more than 18, less than 3, in this, there is no such thing called as point or something of this sort. Only the absolute thresholds are used to exclude or diagnose adrenal insufficiency. So if your baseline ACTH, renin, and aldosterone levels are being obtained with the stimulation test, it must be performed in between 6 and 9 a.m. Measurement of serum electrolytes and plasma renin activity in a basal sample is useful as it helps to interpret measurement of basal aldosterone levels. In primary adrenal insufficiency, all adrenal zones are typically affected and aldosterone will be low with an elevated renin level, whereas in central, renin-angiotensin system is intact, so your aldosterone is unaffected and plasma renin is also unaffected. So this is one term that we all need to know. What is partial ACTH deficiency? Where it happens. It is being documented after pituitary surgery or radiotherapy of the hypopituitary pituitary region, certain patients of trauma, critical illness, or opioid use. And partial ACTH deficiency has also been reported after discontinuation of glucocorticoids. Now, mind you, this could be oral as well as inhalational as well. So if you've got a patient of bronchial asthma who's been on long-term inhalers, even they can manifest as a partial ACTH deficiency. So corticotrophin releasing hormone and or ACTH secretion do not increase in response to the stress, and the basal ACTH levels remain unaffected. This diagnosis does not have a lab test which can actually tell you definitely about it, and diagnosis is mainly clinical. So the next question that comes is that can these cutoffs be different? Yes, depending on your lab test that you're using, There are two types of immunoassays which are mainly used to measure it. There's a monoclonal immunoassay or a polyclonal immunoassay. Based on that, your cutoffs can be different as a response, cortisol response to 250 microgram of post-intropin IV. What about adrenal crisis? Adrenal crisis is basically production of cortisol. The primary glucocorticoid adrenal hormone is inadequate, basically. It can be either because of internal factors, it can be because of external factors. And early recognition and immediate intervention are crucial. We should be able to differentiate between adrenal insufficiency and adrenal crisis. How do you define the same? Acute deterioration in health status, which is associated with the following conditions. Basically, there's no cutoff or definitions. So there's a 2019 definition which I'm using here. So acute deterioration in health status, which is associated with A, absolute hypotension with a systolic BP less than 100, and relative hypotension with a systolic BP more than or equal to 20 mm mercury, lower than the patient's usual baseline. So what is the temporal course? It should ideally improve and resolve within 1 to 2 hours after administering parenteral glucocorticoids. which is marked by a significant reduction in hypotension within your first hour. And there should be a gradual improvement in patient's clinical symptoms over the subsequent 2 hours. Common precipitants, infections, GI and flu-like illnesses, we have got trauma, pregnancy, especially third trimester, childbirth, surgery, exposure to extreme hot or cold weather or other stressful situations, non-adherence to replacement therapy of glucocorticoids or abrupt cessation, coexistent thyrotoxicosis, then levothyroxine therapy initiation in a previously untreated case of adrenal insufficiency. Then you've got medications such as mitotane, mitirapone, ketoconazole, and anti-cancer medications, which can give rise to this. Risk factors include history of adrenal insufficiency or primary adrenal insufficiency. Then you've got ongoing glucocorticoid therapy, including topical and inhalational forms. Then there are certain medications such as levothyroxine, phenytoin, phenobarbital, rifampin, carbamazepine, St. John's wort, ketoconazole, of course, etomidate, one of the frequent offenders, and fluconazole, which affect cortisol metabolism or actually reduce its production. Then you've got anticoagulation agents, which increase the risk of adrenal hemorrhage. Then, of course, magistrol acetate and medroxyprogesterone also affect your cortisol levels. Pregnancy, as I told you, particularly the third trimester, advanced age, IDDM, adrenal mets or adrenal bleeds, adrenal hemorrhage. Then you've got a constellation of endocrine abnormalities in the form of polyglandular autoimmune syndromes, type 1 and type 2 both. So what about lab features? Hyponatremia, hyperkalemia, and hypercalcemia are classical, along with evidences of hypovolemia. Then you get hypoglycemia, which stems from decreased gluconeogenesis and glycogenolysis. CBC-wise, what you can get is a normocytic normochromic anemia, lymphocytosis, and eosinophilia. Then you've got low or low normal ACTH levels, which is secondary adrenal insufficiency, and or high normal ACTH levels, which are observed in primary adrenal insufficiency. If you've got a low aldosterone and high renin levels along with increased TSH levels, it is more in favor of a primary adrenal insufficiency. When we talk in terms of finer points of treatment, infusion method is superior when it comes to hydrocortisone administration. Once you see clinical improvement, gradual tapering of steroids is targeted. If glucocorticoid doses exceed 50 milligram, then mineralocorticoid replacement is unnecessary because they tend to take over the mineralocorticoid action as well. If hydrocortisone is unavailable, you can use prednisolone, methylprednisolone, or dexamethasone can be used. When we look in terms of what is the stress dosing, initial dose of 100 mg IV or IM bolus injection, followed by an additional 200 mg of hydrocortisone as IM or IV over the next 24 hours, with a dosage of 50 mg every 6 hours or as a continuous infusion. You can give 1 liter of normal saline or 5% dextrose in 1 liter of normal saline, followed by maintenance. Mortality rates are unacceptably high, and adrenal crisis can actually contribute up to 10% of mortality in individuals with adrenal insufficiency, purely because it remains undetected, and most of the times it's not suspected. Electrolyte abnormalities and hypotension can cause complications. So you have preventive strategies, in these patients who are already having a adrenal insufficiency, if they come to you, if the fever is more than or equal to 38 degrees centigrade, patients should double their dose of oral corticosteroid until recovery and then gradually decrease it to baseline in 2 days. If you've got a fever more than 39 degrees centigrade, patients should triple the dose of oral corticosteroids and gradually decrease it to baseline dose in 2 days. Then, if you've got a severe infections requiring admission to the ICU, dose has been 50 to 100 milligram replacement every 6 to 12 hours until recovery. If you've got a major surgery, you give a dose of 100 mg during the induction of anesthesia, followed by 50 to 100 mg every 6 to 12 hours until recovery. Minor surgery or major dental surgery, 100 milligram hydrocort during induction of anesthesia, followed by a double oral dose for 24 hours, and then gradually return to the baseline dose. If the patient is in labor, patient should administer 100 milligram of hydrocortisone at the onset of labor, and you follow it up with an additional 25 to 50 mg every 6 hours, and gradually reduce the dose over the next 3 days. If there's significant emotional stress, add 10 to 20 milligram of hydrocortisone to baseline dose. And if there's a prolonged intensive strenuous exercise, again, 10 milligram of hydrocortisone 30 to 50 minutes before exercise can be done. Now, all of these dosage adjustments can be practiced as preventive strategies. But what happens in critically ill? Relative adrenal insufficiency, or SARCI, as commonly we call it. The problem with adrenal insufficiency in critically ill is there's no consensus on diagnostic criteria. Common mechanisms that cause this include a hypothalamic pituitary adrenal excess activation, which leads to increased level of circulating cortisol, HPA impairment, which leads to adrenocortical hyporesponsiveness, along with glucocorticoid resistance. Are there any thumb rules to go about saying that this is indeed that? So what you can do is try to use a thumb rule like this. Change in this from ESICM. This change in baseline cortisol of less than 9 microgram per deciliter, 60 minutes after administration of post-intropin, again high dose 250 microgram. Random plasma cortisol of less than or equal to 10 microgram per deciliter. If at all we need to do a ACTH test, we need to do a high dose test. The problems in literature and my interpretation with these measurements are there's a variability in random serum cortisol levels. There's no fixed pattern in which they change. So it becomes difficult to interpret them in critically ill patients. Secondly, there's a very limited ability to measure free cortisol. What you get mainly is blood circulating cortisol, but free cortisol is something that we are not able to measure and properly, and that impairs your ability to actually react on these values. So there comes the third point. So there is very poor reliability of these tests. And fourthly, a drug which is very commonly being used nowadays, etomidate, it impairs your ACTH response. Then what are the doses and duration required? So 200 to 300 milligram per day of IV hydrocortisone in divided doses, 50 milligram every 6 hours or 100 milligram every 8 hours. Or you can use 40 to 60 mg IV daily of methylprednisolone in divided doses. Now, fludrocortisone is administered as 0.05 or zero point 0.1 milligram once daily for 5 to 7 days. And a typical duration is 5 to 7 days. You can stop it abruptly. There's no need to do any form of tapering. Trials, well, there are many. There's an SCCM meta-analysis. There's a French trial of 2002. Then you've got Approx trial, which was published in 2018. Then you've got a COITS trial, which came in 2010. Corticus, which was seen in 2008. Vanish in 2016, and of course, Adrenal trial in 2018. There's one more about hydrocortisone, Hypres trial, which came in 2016. I've not included it in here. But most of these trials, when we look at it, they do not define adrenal insufficiency as an independent entity in critically ill patients. There are no cutoffs. You are not able to talk about what are the finer points of cutoffs or what are your targets here. But yes, they are quite okay in the sense that they all recognize the fact that probably your pressure dependence comes down and your hemodynamic stability improves if these patients are given supplemental steroids. Dose recommendation is again hydrocortisone. We've discussed this before, 200 mg per day. Better to give it as a continuous infusion. It has even come in surviving sepsis trials.
Aspirants, if you have any question, you may bring it up right now.
I do understand this is going to be a tough topic actually because it involves a lot of physiology and basics of physiology.
Hello, Nikhilesh. How are
Hi,
you?
Akhilesh, how are you?
That was fantastic presentation. Yeah, a lot of concepts and misconceptions got very clear. And diagnosis of adrenal insufficiency is challenging. I agree. And I and assessment of adrenal insufficiency in chronic illness is probably very difficult. There are a lot of factors which may contribute to adrenal insufficiency, and to elicit adrenal insufficiency is very difficult. And most of the times, the tests that we do, this cortisol test and all that, so people are not really aware of how do we do this test and how do we interpret. Interpretation is also very difficult, you know. So I think any other gold standard, test that can help us, apart from this cortisol test and dexamethasone suppression test also, you talked about dexamethasone suppression test also. So how in practical day-to-day life do you really think that this test will be really helpful as far as the assessment of adrenal insufficiency is concerned?
Look at it this way that it could be what you may be dealing with, maybe a primary patient, what you may be dealing with, maybe a relative adrenal insufficiency. Most of the patients that we see in ICUs have a relative adrenal insufficiency. And this
Yeah,
becomes absolutely difficult thing to diagnose by bedside. What you are going
yeah,
to do is probably suspect it clinically and use it. So many times we try to use it as a gut feeling and use it. And many a times we've been able to successfully wean off the pressures, which is what various trials have demonstrated as per evidence. But
Yeah.
very difficult to get salivary levels, which are supposed to be more accurate. I doubt if, there are very few setups which may be doing salivary levels for that matter. I'm not sure. My one doesn't do. And there's one question Bilal has put actually. Any type of shock, is it recommendable to use steroids? I won't use say any type of shock. If you've got a well-documented cardiogenic shock, definitely no. But in all other instances, probably doesn't harm. The dose of hydrocortisone up to 200 to 200 mg doesn't harm you. You would be able to actually, uh, you know, see an effect of being able to wean off pressors. Certain times, even using midodrine as an anecdotally used drugs in patients whom we have not been able to wean off pressors despite steroid, but main thrust is steroid only. And let me tell you, it is clinical suspicion. The whole literature is mired with controversies and inconclusive statements.
Yeah. So, English, in septic shock, there is adrenal insufficiency. So, is it due to the hypoperfusion of the adrenals, or is it related to the pituitary adrenal axis that got affected, or anything else that you would like to highlight upon
It is
this point?
basically HPA. It is basically an HPA axis disturbance. Along with that, you have glucocorticoid resistance. So both the
Yeah,
things come into play together. And as I told, like mean, relative adrenal insufficiency is something you only suspect clinically. There's no way you can nail it in lab, stating that this is what it is. I'm yet to
yeah,
see results of that type. But still, yeah, I mean, patients with adequate cortisol levels, severe bad shocks, we are able to wean off pressors. I mean, this may be just purely a practice. What should I say? Purely anecdotal experience that I may be telling you because I haven't published or I haven't done any major things on that. But whatever data is there in medical domain, they also talk about it. So from my point of view, mainly if you've got an established patient of adrenal insufficiency, yes, definitely yes. But other than that, probably giving a small dose of hydrocortisone never hurt anybody.
yeah. Oh, that's fantastic. Yeah. So, it's probably the excess of catecholamines. Also, do you think excess of catecholamines also contribute to uh, affection of the pituitary adrenal?
I could not get it, Akhilesh. Can you be a little bit louder?
Yeah, I said, I mean, do you think the excess of catecholamines that are released and the surge response that is there in the septic patients, would it also contribute to the inhibition of the pituitary adrenal axis?
It would. It would. Actually, the problem here is that when we look at the physiological effects, what you get is a deficiency in epinephrine, and what you
Yeah,
get is a slightly elevated norepinephrine levels. So, what is
yeah.
happening here is that you get a basal, I discussed that actually your blood pressure levels are slightly lowered.
Okay, any other questions? Can we get the chat box? I think there are
Somebody asked how long
questions.
we have to wait for send serum cortisol after giving IV steroid. This is Akshat. Ah. So now look at it this way. It depends on the dose of steroid that you're using. I'm yet to come across a patient in whom we have given less than 40 mg. So when you talk about using a dose of less than 40 mg, uh, there are very few and far in between. If you're giving anything more than 40 mg, uh, even testing for ACTH becomes a problem. And random serum cortisol level values, you have to fall back upon the ASICM guidelines, which talk about a level of less than 9. I think Dr. Kaustav has asked this. Through dental surgery, how to manage cortisone level in your slide. I could understand the question, Kaustav. And Mohammad Irfan has asked, can steroids be stopped once hypertension settles? Absolutely. I mean, look at it this way. You do not need to taper and take away that. If the patient is, of course, a documented adrenal insufficiency, yes. But other than that, using it purely for this indication or adrenal crisis, after 5 to 7 days, it can be stopped and it can be stopped abruptly. And Sarki is, yes, indeed the same as relative cortisol deficiency. This is Shrikant who's asking. So, Kaustav, can you clarify your question? I mean, all the trials have been given, so you can all go through those references actually. A little bit, maybe you can know about those trials, but most of them again talk about probably getting you into a better hemodynamic status. There are some comparisons about hydrocortisone in combination with fludrocortisone. There is one trial which has combined it with vasopressin. So basically, your hemodynamic response is what they have looked at.
Any other questions?
So two new messages.
There's one more question, Nikhilesh. Pre-renal acute injury may lead to adrenal hypoperfusion. Do you think about this? Or do you think
I
this
think
is
it will be the other way around. I think, Bilal, what has happened, as I mentioned, it is actually adrenal insufficiency which can lead to hypoperfusion. When we talk about one-creatinine ratios and likelihood of pre-renal etiology, you need to give more fluids. That is why hypovolemia comes in when it comes to adrenal insufficiency. So it's the other way around, you know. And when we are talking about dental surgery, okay, uh, okay. See, what happens is you have patients who are documented adrenal insufficiencies. So, dental surgery is a time of stress. So, all these patients during the times of stress should have a supplemental dose of steroid so that they don't go into a crisis. So, this is what I meant when I said that during dental surgery, if you've got a documented patient of hypoadrenalism, these patients would need a additional supplement or an incremental dose. Any further questions are there?
No, sir, we don't have any more questions. Well, sir, this was a very nice session. It was very innovative, interactive, and informative. Thank you, sir.
Thank you. Thank you, everyone.